Okay, so today we're going to continue with our discussion of airspace disease, and we will start with eosinophilic lung disease. We'll talk about the definition, etiologies, and the differential diagnosis. So there are three possible definitions for eosinophilic lung disease. We can have pulmonary opacities with peripheral blood eosinophilia, abbreviated PIE. There, the peripheral blood count, the eosinophils can be greater than 500 in the peripheral blood count. We can have lung tissue eosinophilia confirmed by biopsy, or we might have increased eosinophils in bronchoalveolar lavage fluid. So there, if the eosinophils are greater than 5 to 10% in terms of the count within the BAL fluid. So the tissue to blood ratio of eosinophils is about 100 to 1. So these accumulate within the tissues, and their function is that these are granulocytes that develop in the bone marrow. They're carried in the blood to epithelia exposed to the external environment, especially this respiratory, gastrointestinal, and GU mucosa. They contain enzymes that damage parasitic worms and modulate mast cell dependent hypersensitivity reactions. Hence, these are very important for allergic phenomenon. So if we start with this case, if I tell you this patient has a cough, fever, eosinophil count is 1,000. We look on the chest x-ray, we notice a consolidation here in the right upper lobe bordering on the minor fissure. And then a few days later, we notice that that seems to have gotten better, but now we have some consolidation here in the periphery of the right middle lobe. We also have some opacity here in the periphery of the left mid-lung. So it seems like these consolidations are migratory. So what do we call this if we have consolidations, especially if they might be peripheral that are migratory when we're dealing with eosinophilic lung disease? Well, this represents simple pulmonary eosinophilia or Loeffler syndrome. So this consists of blood eosinophilia. Pulmonary symptoms are usually mild, and the important thing is that the symptoms are present for less than a month. So it's usually self-limited. We can have non-segmental, transitory, or migratory, spontaneously clearing consolidations, and if there is a biopsy done, the pathology will show eosinophils and histiocytes within the alveolar spaces and walls. Now, when this was first described in Loeffler's original series, it is thought now that most of those patients probably had Ascariasis as opposed to an idiopathic cause of their disease. But in about 1/3 of cases, the cause remains unknown, and so this might represent a reaction to some unknown inciting agent. The important thing is that the disease usually resolves in less than a month, and on chest radiographs we might see unilateral or bilateral transient migratory opacities, especially in a peripheral distribution. Now, if I give you this history and tell you this patient has a cough for 6 weeks and a history of asthma, this patient also has an elevated eosinophil count. So a few important things here. Again, we have peripheral consolidations, but we notice that the symptoms have been present for greater than a month. And we've also said that the patient has asthma. So how does this fit in with our discussion of eosinophilic lung diseases? Well, we see on the CT that indeed these consolidations are peripheral in distribution, and with the history of asthma and symptoms present greater than a month, we should think about chronic eosinophilic pneumonia. So this is an idiopathic condition. It's characterized by chronic infiltration of the lung with eosinophils. Symptoms are usually present for greater than a month. It can progress to respiratory failure, especially if the diagnosis is delayed. So about 50% of the patients have asthma, about 5 to 10% have allergic rhinitis and nasal polyps, and we can see that the peak incidence is about 40 to 50 years of age, and females outnumber males. The important thing about suggesting the diagnosis is that this responds to steroids, and it can relapse in the first 6 months if the steroids are discontinued. Less than 10% of cases resolve spontaneously without steroids. So the characteristic findings are pulmonary symptoms, peripheral blood eosinophilia, seen in about 90% of patient's peripheral distribution of consolidations on the chest radiograph, increased eosinophils in the bronchial alveolar lavage fluid, and rapid response to steroids. So on the chest radiograph, we will characteristically see these peripheral consolidations. So this has been described as the photographic negative of pulmonary edema in some cases. Remember that pulmonary edema is usually perihilar in distribution. Here the consolidations are peripheral in distribution, and these consolidations may be chronic. CT can often demonstrate the peripheral distribution of the consolidations if it's not obvious on the chest radiograph. And here's such a case where we had a 29-year-old man, history of asthma, progressive cough, and shortness of breath, and he had some history of working with carpets without a mask. You can see his white count was elevated, eosinophil count was elevated, and the eosinophil count was also elevated within the bronchoalveolar lavage fluid, 88%, when normal should be about 5 to 10%. You can see on the CT, though, we have these peripheral consolidations. It was not really apparent on the chest radiograph, the peripheral distribution of these consolidations. So this patient was given a diagnosis of chronic eosinophilic pneumonia, and you can see the rapid response to steroids. 9 days after steroids, the eosinophil count normalized, and you can see that the pulmonary opacities have largely resolved. So it's important to suggest this diagnosis, as the response to treatment can be dramatic. Now, there are parasites that can also cause eosinophilic pneumonias. So what parasites can be associated with eosinophilic pneumonias? Well, Ascariasis is one of the big ones, but so worms, these parasitic worms, especially those that have a migratory phase through the lungs, these are the types that are associated with eosinophilic pneumonia. So the larval stages of these worms might have migratory phase through the lungs. They can cause pulmonary consolidations with blood or tissue eosinophilia, and you can see the most common types of worms here listed most common types in the United States I've listed here, and this can give you transient migratory non-segmental or Loeffler-like consolidations. So the life cycle, of course, is pretty disgusting. The eggs become infective in the soil, and then when the eggs are swallowed, the larvae then penetrate the duodenal wall, enter the bloodstream, migrate to the lungs, and then from there they are coughed and swallowed, and then the adult worms develop in the small intestine, and then they form the eggs, which are fertilized, and then the eggs are released into the soil, and the life cycle goes around again. So these are worms that have a migratory phase through the lungs, so these can be associated with eosinophilic lung disease. Drug reactions can also be associated with eosinophilic lung disease. So DRESS is the abbreviation for drug rash with eosinophilia and systemic symptoms. So the presentations can vary from simple eosinophilia to severe acute eosinophilic pneumonia-like syndrome. The most common drugs, again, I've listed them here, that might be associated with eosinophilic lung disease. So drugs that are associated with consolidation: methotrexate, nitrofurantoin, salicylates, sulfonamides, penicillin. Adenopathy as a reaction to drugs, we can get that with the anti-seizure medications like phenytoin and trimethadione. Pleural effusions, we can see that with nitrofurantoin. In interstitial lung disease, this can be associated with nitrofurantoin and methotrexate. And all of these might also be associated with eosinophilia. So here's an example of a drug reaction for methotrexate. You can see a kind of peripheral distribution of consolidation here. Kind of resembles organizing pneumonia in this case. If I tell you that the biopsy in this patient showed necrotizing vasculitis and tissue infiltration with eosinophils, what would be the diagnosis? Notice again we have consolidations, predominantly peripheral, and the peripheral distribution here is confirmed on the CT scan. So if we're talking about eosinophilic lung disease associated with necrotizing vasculitis and consolidations like this in the lung, well, we should be thinking about Churg-Strauss syndrome. So this is an allergic angiitis and granulomatosis. It is associated with elevated ankle levels, and This can result in necrotizing vasculitis with marked peripheral eosinophilia. Often this is associated with asthma. So the characteristic clinical triad is asthma or allergic rhinitis, marked peripheral eosinophilia, and systemic vasculitis involving 2 or more extrapulmonary organs. So diagnostic criteria I've listed here to make the diagnosis of Churg-Strauss syndrome, and with using these diagnostic criteria, 4 out of 6 gives you 85% sensitivity and 99% specificity for making the diagnosis. Histologic criteria would look for necrotizing vasculitis, tissue infiltration with eosinophils, and extravascular granulomas, so-called eosinophilic abscesses. So these granulomas are centrally necrotic nodules, tightly packed eosinophils, surrounded by multinucleated giant cells and macrophages. So this may result from a hypersensitivity reaction to some unknown inhaled antigen. And so the disease may involve in 3 stages. There's an asthmatic phase, there's an eosinophilic phase where we have blood and tissue eosinophilia, and then this can affect the heart, can affect the lungs, and then the vasculitic phase, which can affect many organs as I've listed them here. So the upper airway and pulmonary involvement occurs in about 70% of cases. Patients can have transient, patchy, non-segmental consolidations like Loeffler. Sometimes it might resemble chronic eosinophilic pneumonia. Patients might also have pleural effusions. And then cardiac involvement can also occur, resulting in myocarditis, pericarditis, or coronary arteritis. So as far as the pulmonary manifestations, we might get peripheral opacities, central lobular nodules, or bronchial wall thickening. So here we have some nodular type opacity here, some peripheral, more ground glass kind of opacities there on the left side. So here again, some more examples. Here's some peripheral ground glass opacity, a little bit more of a confluent opacity in this case there in the right middle lobe. Now, asthma is also associated with eosinophilia, and the eosinophil is the most characteristic inflammatory cell associated with the airway inflammation in asthma. So asthma can also be described as chronic eosinophilic bronchitis. So the eosinophils then will accumulate around the airways, giving you an eosinophilic bronchitis. So you'll have smooth muscle hypertrophy, which are the straight arrows here, and peribronchial eosinophils, which represent these curved arrows. So these cells out here represent the peribronchial eosinophils, and then this then results in narrowing of the airway and small airway disease in patients with asthma. So the manifestations of that on chest radiograph, we will see air trapping and peribronchial thickening. We might also have atelectasis from mucus plugging. The peribronchial thickening can be subtle. You have to look very closely on the lateral view to notice it, and if you do, you'll see some subtle peribronchial thickening here around these airways. On the lateral view, they just look a little bit thicker than normal. So peribronchial thickening, especially in a child, a common finding associated with asthma. And now we can see that also on CT. So here's a nice example here. You can see the peribronchial thickening around these small airways here and here. Notice also there's mosaic attenuation, these areas of lower attenuation scattered throughout the lung parenchyma, representing regions of air trapping. And here's another example of a patient with asthma. You can see mosaic attenuation, areas of decreased lung opacity, areas of increased lung opacity. Notice that the blood vessels are more prominent in these areas of increased lung opacity. So this patient also has mosaic perfusion, and in this case, this is from air trapping as a result of asthma. So that can be accentuated on expiratory views. So if we're looking for air trapping, easier to see on expiratory views. So you can see that these areas of air trapping are more loosened here on the expiratory views as the air is able to get out of the more normal regions of the lung, but not in these regions where the smaller airways are more severely obstructed. So here's a patient with asthma, has an elevated left diaphragm, funny looking opacity here along the left hilum. Now if I show you the lateral view, you should now be able to tell me the diagnosis. Notice that there is some volume loss on this side, and then we have this line that is extending down here on the lateral view. Well, this is a patient with left upper lobe atelectasis, and that was from mucus plugging. So mucus plugging in asthmatics can commonly result in lobar atelectasis, and then when the obstruction is relieved, you can see everything goes back to normal on the follow-up chest radiograph. Another patient with asthma, these patients can also have eosinophils. Notice that we have this funny kind of tubular opacity here in the right upper lobe. These other smaller tree and bud opacities also. So what should we be thinking about here? Well, this represents an area of mucoid impaction. You can see these branching tubular opacities represent mucoid impaction. And in an asthmatic, this represents allergic bronchopulmonary aspergillosis. So that can also be associated with eosinophilia. So we've covered this before in an earlier lecture, but this can give you bronchiectasis, mucus plugging, atelectasis, and these patients often have peripheral eosinophilia. So the hallmark is bronchiectasis, especially with mucus plugging. So there's another example here where we have some mild bronchiectasis. Notice the extensive peribronchial thickening here, which is also typical of asthma, a little bit of mosaic attenuation, secondary to the air trapping in that case. So mucoid impaction, if we see this in an asthmatic, see these tubular opacities here is a nice example of some branching tubular opacities, especially if they're higher in attenuation. So with allergic bronchopulmonary aspergillosis, the mucoid impaction can be higher in attenuation. So these are some typical manifestations of ABPA in an asthmatic. Now, if I tell you this patient had a history of binge smoking, had fever for 3 days, hypoxia, no peripheral eosinophilia, but there was a large amount of eosinophils in the bronchoalveolar lavage fluid, what would be our diagnosis here? Now notice that there is interlobular septal thickening, some thickening of the fissures, some kind of centrolobular ground glass opacity. So this is the appearance of pulmonary edema, but given this history and since we're discussing eosinophilic lung disease, what do we call this? Well, this is acute eosinophilic pneumonia. So this is an idiopathic disease characterized by acute febrile illness, pulmonary symptoms, and infiltration of the lung by eosinophils. Now, this might represent an acute hypersensitivity reaction to an inhaled antigen, resulting in the eosinophils then being recruited to the lung, and when they release their contents, that causes the lung damage, increased vascular permeability, causing the pulmonary edema. So with acute eosinophilic pneumonia, these patients do not have the typical peripheral consolidations we've come to associate with the other causes of eosinophilic pneumonia. Here, the radiological manifestations look more like pulmonary edema. They may not have peripheral blood eosinophilia initially, although it tends to occur at some point during the course of the disease. And this is not associated with asthma as opposed to chronic eosinophilic pneumonia. So this can be associated with smoking, especially binge smoking. So there are diagnostic criteria for making the diagnosis. Opacities in the lung parenchyma, hypoxemic respiratory failure, very acute severe illness, elevated eosinophils in the bronchoalveolar lavage fluid, and excluding other causes of eosinophilic lung disease. The importance of making this diagnosis is that this does respond to steroids. So the radiological findings probably result from pulmonary edema, so we will see interlobular septal thickening, ground glass opacities, pleural effusions, but this does not give you a peripheral predominance of consolidations like those other causes of eosinophilic pneumonia like we have seen. So at acute eosinophilic pneumonia, bilateral consolidation similar to pulmonary edema, ground glass opacities, interlobular septal thickening, the picture of pulmonary edema. So here's an example here. This patient had a young patient with severe shortness of breath after a week of binge smoking, widespread bilateral consolidations, and You can see that also on the CT scan, and this patient had elevated eosinophils in the bronchoalveolar lavage fluid, so this was also a case of acute eosinophilic pneumonia, and you can see the rapid response to steroids after 3 days, a marked improvement in the pulmonary consolidations here. Now moving on, if I tell you that this patient had a very elevated eosinophil count of 2,000 for about 8 months, has these kind of nodular lesions here. Notice a little bit of ground glass surrounding this one. And then some strange findings here on examination of the heart with MR. Notice that there is some endocardial enhancement. This area here does not enhance, so this represents a thrombus. So we have some mural thrombus here with some endocardial enhancement. This is the thrombus there on T1 weighted imaging. So what is going on here? This represents idiopathic hypereosinophilic syndrome. So this is associated with very high eosinophil counts. We rule out parasites or other causes of secondary eosinophilia, and the end organ damage is from the eosinophils. Initially, this was called eosinophilic leukemia because of the very elevated eosinophil count in these patients. So the morbidity and mortality, interestingly, is related to cardiac involvement. These patients can develop endocardial fibrosis and restrictive cardiomyopathy, so-called Loeffler's endocarditis, which is any type of cardiomyopathy associated with abnormality in eosinophils. They can develop mural thrombi also, and they can also develop thromboembolic disease, as I've outlined there. So many organs can be infiltrated with eosinophils. As we've seen here, most of the findings can be secondary to heart failure, such as pulmonary edema and pleural effusions, and the infiltrates from eosinophilic pneumonia is less common. These patients can develop nodules, so sometimes these nodules might have ground glass halos here. So it's a very unusual disease, but might also be associated with this finding of nodular opacities with ground glass halos, idiopathic hypereosinophilic syndrome. Now, with elevated eosinophils, all patients with elevated eosinophils might develop endomyocardial fibrosis, or so-called Loeffler's endocarditis. So here the eosinophils, by releasing their contents can damage the lining of the heart. So this results in endocardial fibrosis manifested by this enhancement here, this subendocardial enhancement. So this is the fibrotic regions that are enhancing, and these patients can also develop mural thrombi, clots here within the heart. The ventricles can become stiff, and these patients can develop a restrictive cardiomyopathy. Notice the atria are dilated here because of restrictive cardiomyopathy. This patient also has large bilateral pleural effusions. So this subendocardial enhancement associated with mural thrombi can affect both ventricles. So this is a manifestation of Loeffler's endocarditis. So these are the eosinophilic lung diseases that we have kind of touched upon in this discussion of eosinophilic lung disease. So if we have peripheral consolidations and eosinophilia, what is in our differential diagnosis? So simple pulmonary eosinophilia or Loeffler syndrome, chronic eosinophilic pneumonia, parasitic infections, drug reactions, Churg-Strauss, those are the things to consider. Now, besides eosinophilic pneumonia, besides COVID, what else can be in our differential for peripheral consolidations? Well, if I tell you this patient has fever, cough, no eosinophilia, but this disease responds well to steroids, what interstitial lung disease is associated with peripheral consolidations? And there the answer is cryptogenic organizing pneumonia, or COP. So you might be the first one to suggest this diagnosis when you notice that the opacities are peripheral in distribution as illustrated here. If we tell you that this patient has cough, shortness of breath, no eosinophilia, notice that there are peripheral ground glass opacities, also some more lucent areas, some areas of central lobular emphysema. So this patient is a smoker. So if we have a smoker with a peripheral distribution of ground glass opacities, what interstitial lung disease do we think about here? Well, here we think about desquamating interstitial pneumonitis. So that can give you peripheral ground glass opacities, and these patients are usually associated with smoking, so you might see this evidence that the patient is a smoker. If I tell you that this patient has acute shortness of breath, notice this peripheral opacity here. Some right hilum looks a little bit enlarged. So this, of course, is the Hampton's hump that is associated with pulmonary embolism. This patient has a pulmonary infarct here. So that's what gives you the Hampton's hump. You can see the clots there within the pulmonary arteries in this patient. So this patient is short of breath and has these upper lobe opacities. So whenever we have upper lobe opacities, diseases to consider, of course, we might think about tuberculosis, but sarcoid is another disease to consider if we have chronic upper lung opacities, as in this case. This was a case of sarcoid. So the differential diagnosis for peripheral consolidations, eosinophilic pneumonias, COVID, of course, nowadays, cryptogenic organizing pneumonia, DIP, especially if it's ground glass in a smoker, pulmonary infarction, alveolar sarcoid, if it is predominantly in the upper lobes. All right, so moving on in our discussion of airspace disease, let us move on now to pulmonary hemorrhage. So diffuse pulmonary hemorrhage or diffuse alveolar hemorrhage, the characteristic triad for this is hemoptysis, anemia, and alveolar opacities. So the opacities are usually non-specific on the chest radiograph. They tend to be bilateral and will resolve in a few days. You can have extensive diffuse pulmonary hemorrhage with a relatively normal chest radiograph. On CT, often the abnormalities are ground glass opacities like we see here. Might have some septal thickening, might even have crazy paving, but very commonly ground glass opacities in association with diffuse pulmonary hemorrhage. So if we have a patient with hemoptysis, anemia, and ground glass opacities like that on CT, you might suggest pulmonary hemorrhage. If we tell you that this patient has hemoptysis and kidney failure, and there's pulmonary hemorrhage here from these consolidations there in the chest, so what do we think about here? Well, here we can have various pulmonary-renal syndromes where we get pulmonary hemorrhage and glomerulonephritis. We can have ANCA-associated vasculitis, especially microscopic polyangiitis, Goodpasture syndrome, and then there are collagen vascular diseases, most commonly SLE, that can also be associated with pulmonary hemorrhage and renal disease. So starting with Goodpasture syndrome, this is because we have anti-glomerular basement membrane, this antibody, which then cross-reacts with the lung tissues, and that's what results in the pulmonary hemorrhage. So this is an autoimmune disease characterized by pulmonary hemorrhage, glomerulonephritis, and this particular antibody, which can be found in the serum, lung, or kidney. So that antibody cross-reacts with the lung basement membrane, resulting in pulmonary hemorrhage. Commonly, these are male patients, about 90% of the time. These patients can have hemoptysis, iron deficiency, anemia, shortness of breath, pulmonary hemorrhage, which usually precedes the renal disease. So these patients can have bilateral consolidations, usually resolves in a few days, and you might have residual linear or reticular opacities. So here's an example of Goodpasture syndrome, predominantly ground glass opacities there within the lung, immunofluorescence here, staining for the antibody, telling you it's a positive diagnosis for Goodpasture syndrome. So if I tell you that this patient has hemoptysis and elevated P ankle levels, what disease would we think about here? Notice the ground glass opacities representing our regions of pulmonary hemorrhage. This is microscopic polyangiitis. So this is a non-granulomatous systemic small vessel vasculitis. And these patients might have systemic symptoms. They might have neurologic disorders like peripheral neuropathy. About a third of them develop diffuse pulmonary hemorrhage. 75 to 80% will be ANCA positive, usually P ANCA positive in these cases. If I tell you this patient has cough, hemoptysis, anemia, so here's pulmonary hemorrhage here with the consolidations on the chest radiograph, ground glass opacities on the CT, but there is elevation of the C ANCA, and notice that the patient also has pretty extensive sinusitis here with also involvement there of the nasal bones. So what does this represent? This represents Wegener's granulomatosis. So in these patients with Wegener's, most of them will have elevated C ANCA levels, and these patients can develop then these consolidations here within the lungs as a result of pulmonary hemorrhage. So Wegener's granulomatosis is a granulomatous vasculitis characterized by involvement of the upper and lower respiratory tracts. There is a form called limited Wegener's, which can affect about 10% of patients. Here you can have lung involvement without renal or systemic involvement, and the upper respiratory tract might also be involved. So most of these patients will have elevated ANCA levels, and in most cases that will be elevated C ANCA levels, and they might have also upper respiratory symptoms. So you can have focal opacities, usually peripheral. These may be masses or consolidations, although they do tend to be multiple, and in some cases cavitation may also occur. So remember that Wegener's was in our differential diagnosis for cavitary lesions in the lungs, and it can affect the airway. So tracheal and bronchial stenosis can also occur in cases of Wegener's granulomatosis. So the consolidations for pulmonary hemorrhage, so these can be predominantly ground glass opacities. Now, there are immune complex collagen vascular diseases that can also result in diffuse pulmonary hemorrhage. Again, we can see ground glass opacities. Of these, the most common would be SLE, although pulmonary hemorrhage is rare in SLE, but it's the most common of the collagen vascular diseases associated with diffuse pulmonary hemorrhage. And we can also have immune complex vasculitides associated with diffuse pulmonary hemorrhage, and I've listed some of the diseases here that can do that. One other disease we need to talk about for pulmonary hemorrhage, that's idiopathic pulmonary hemosiderosis. So this disease results in diffuse pulmonary hemorrhage without renal or immunological abnormalities, usually affects children, and it's the most common cause of diffuse pulmonary hemorrhage in children, can result in hemoptysis and anemia. So these patients can develop consolidations that can resolve in a few days and can be replaced with reticular opacities. Repeated episodes of hemorrhage can result in pulmonary hemosiderosis and sometimes progressive pulmonary fibrosis in these patients. Now, what else can give you bleeding in the lungs? Well, it's an unusual complication of coagulopathy, but it can be associated with anticoagulation. This was an example of diffuse pulmonary hemorrhage in a patient with too much Coumadin. You can also see it with DIC, thrombocytopenia, drugs such as some of the drugs listed here. Penicillamine is the unusual one, so as a side effect, penicillamine can be associated with pulmonary hemorrhage and acute glomerulonephritis, very similar to Goodpasture's syndrome. Of course, lung injury can also give you pulmonary hemorrhage. We can see it with trauma and contusions. This patient has a pneumothorax here. Severe infections from necrotizing pneumonias and ARDS also. And in immunocompromised patients, diffuse pulmonary hemorrhage might be caused by leukemia infections and Kaposi's. Usually these are terminal events when they occur. So we've gone through some of these causes of diffuse pulmonary hemorrhage: Goodpasture syndrome, ANCA-associated small vessel vasculitides, microscopic polyangiitis, Wegener's granulomatosis. Diffuse pulmonary hemorrhage is pretty rare in Churg-Strauss, and an immune complex disease or collagen vascular diseases. The most common of those is SLE that can result in diffuse pulmonary hemorrhage. Okay? And then we've covered some of these causes also that can cause pulmonary hemorrhage. So moving on, other causes of airspace disease. Well, infiltration with cells can also result in airspace disease in the lung. What primary lung neoplasm is associated with airspace disease and consolidations? Well, this is invasive mucinous adenocarcinoma, which used to be called bronchoalveolar carcinoma. So one manifestation of this is as airspace disease. It can be multifocal. So invasive mucinous adenocarcinoma can do that, always in the differential for chronic airspace disease. There's an inflammatory condition that can also give you chronic airspace disease. Notice we have these nodular opacities. Here we have more focal parenchymal opacities here. Look at the striking upper lung distribution of these opacities, and then some of these have irregular margins. If you use your imagination, you might notice that there seems to be a perilymphatic distribution of some of these nodules. Notice the studding of the fissure here. So this is sarcoid. Sarcoid can also give you that appearance, and it can result in air bronchograms, airspace disease with air bronchograms. So here's a patient who has airspace disease here in the right lower lung. Notice the marked widening of the mediastinum here. This patient has lymphadenopathy. So massive lymphadenopathy here in airspace disease. This is a patient with lymphoma. So in this case, the infiltrative disorder in the lung is secondary to lymphoma. So neoplasms that can give you airspace disease, mucinous adenocarcinoma, lymphoma, those are the neoplasms to consider. So both of those can be associated with air bronchograms. So parenchymal involvement with lymphoma can occur with Hodgkin's or non-Hodgkin's. With Hodgkin's, the parenchymal involvement is almost always accompanied by lymphadenopathy, unless it's recurrent disease. And often the parenchymal involvement spreads out from the adjacent nodes, direct invasion from the nodes into the adjacent lung parenchyma. So air bronchograms can be seen with that. We can also have non-Hodgkin's lymphoma. There you don't have to have lymphadenopathy, so non-Hodgkin's can also give you airspace disease, as in this example here. So for cells then, for alveolar consolidations or airspace disease, air bronchograms, we can think about invasive mucinous adenocarcinoma, lymphoma, alveolar sarcoid. So moving on, here's another appearance that we need to be familiar with. So we have ground glass opacities with interlobular and intralobular septal thickening. This, of course, is crazy paving. Now, in this particular case, notice the patient has a cavitary lesion. So this patient has crazy paving with a cavitary lesion. How do we put this together? What might this represent? Well, the disease, the typical disease associated with crazy paving is pulmonary alveolar proteinosis. And if I tell you this patient does have pulmonary alveolar proteinosis, how do you make sense of the cavitary lesion? Well, patients with pulmonary alveolar proteinosis are susceptible to all kinds of infections. One of them is nocardiosis. So this was nocardiosis infection in a patient with pulmonary alveolar proteinosis. So moving on now to protein as a cause of airspace disease. Pulmonary alveolar proteinosis, there's a primary form that affects the lung, and then there are secondary forms that are secondary to other diseases like acute silicoproteiноsis. Pneumocystis pneumonia can also be associated with accumulation of an alveolar protein within the air spaces, and immunodeficiencies, underlying diseases like lymphoma and myeloid leukemia, so they can also be associated with secondary pulmonary alveolar proteinosis. So for diagnosis, PAS stain, so it stains with PAS stain to make the diagnosis here of alveolar proteinosis. So what happens here is accumulation of a large amount of proteinaceous material in the alveoli, and there's impaired removal by macrophages of a surfactant-derived phospholipid, and so that's why the protein then builds up in the alveoli. These patients are susceptible to infection with nocardia, aspergillus, or just regular mold. And so we might see bilateral consolidations here on the chest radiograph, might resemble pulmonary edema. Often the patients are not as symptomatic as the radiograph would suggest, so the x-ray looks much worse than the patient. So crazy paving, so this appearance is when we have these ground glass opacities with interlobular and intralobular septal thickening, as in this example that we looked at earlier. So we should all be familiar with the appearance of crazy paving on CT. So it's given that name because of this type of surface that is used for paving the garden floors. So this is called a crazy paving pattern. So these you can imagine these as representing the secondary pulmonary lobules here that are outlined by thickened interlobular septae with superimposed ground glass opacity. Now with crazy paving, you not only get ground glass opacity with thickened interlobular septae, but also there's thickening of intralobular septae. If you look inside the secondary pulmonary lobule, notice that you see reticular opacities also inside the secondary pulmonary lobule. Treatment of pulmonary alveolar proteinosis is usually pulmonary lavage. So here's an example where the patient was lavaged to remove the protein, and you can see the follow-up chest radiograph there in this patient after lavage. Right after the lavage, there might be some increased opacity representing the lavage fluid there, but that clears fairly rapidly. Now, acute silicoproteinosis can also result in accumulation of protein within the air spaces. So this is usually secondary to massive exposure. Commonly in sandblasters, these patients will have ground glass opacities as you see here, and they might also have a nodular patterns also on the background of that. Now, what are other causes of crazy paving? Well, it's a very non-specific kind of appearance. So at one time it was thought to be pathognomonic for pulmonary alveolar proteinosis, but now we know that it is not specific, and it's actually more likely, if you encounter it in clinical practice, it's more likely to represent something else besides pulmonary alveolar proteinosis. So pulmonary edema, ARDS, very common cause of crazy paving, pneumocystis, pneumonia, diffuse pulmonary hemorrhage, sarcoid, sometimes mucinous adenocarcinoma can do it, and lipoid pneumonia. All of these have been associated with crazy paving. Here's an example of crazy paving from pulmonary edema, crazy paving here from diffuse pulmonary hemorrhage, patient with ARDS who has crazy paving, viral infection from SARS here, a patient developed crazy paving there, and here is a case of bronchoalveolar cancer, a mucinous adenocarcinoma with crazy paving, pneumocystis pneumonia with crazy paving. So anything that might give you consolidations, especially ground glass consolidations in the lung, can be associated with crazy paving. Here's an example of lipoid pneumonia, and pretty unusual for sarcoid to do it, but here is an example of sarcoid causing crazy paving. So we've covered many things here, and I hope by now that you understand what our differential might be for chronic airspace disease. So if we go through the things that fill the alveoli for chronic airspace disease, if it's pus, it could be tuberculosis, fungal infections, eosinophilic pneumonia here for thinking of inflammatory conditions, and lipoid pneumonia. Cells for neoplasms, mucinous adenocarcinoma, lymphoma, and then alveolar sarcoid can also give you airspace opacities with air bronchograms within the lungs. We've seen cases of pulmonary hemorrhage, so these patients might have recurrent hemorrhage that might resemble then chronic airspace disease. So we've discussed the pulmonary-renal syndromes, and then we've also talked about protein, alveolar proteinosis, especially if the patients have recurrent bouts of alveolar proteinosis, so they may come back multiple times with airspace disease from pulmonary alveolar proteinosis. All right, so that concludes our talk for today. Thank you for your attention, and we'll see you next time.